Hello, my name is Lassaletta. I am head section of otology at La Paz University Hospital in Madrid. I'm also a member of the hearing group. Today I want to talk to you about the usefulness of electric ABR to assess the functionality of the cochlear nerve. And why is this important? Because it can help us deciding between cochlear implant and ABI in patients with vestibular schwannoma. I will divide this talk in three parts. First, to talk about our experience in cochlear implantation in patients with vestibular schwannoma. Second, to assess the functionality of the auditory nerve using an intracochlear test electrode in standard implantees. And third, to assess the usefulness of this tool in difficult patients, specifically patients with a vestibular schwannoma. So we'll start talking about implantations in patients with vestibular schwannoma. Here you can see an MRI. This is a NF2 patient. So you can see both tumors on the right and the left side. And we all know that in the long term, these patients normally develop profound bilateral hearing loss. So what are the options for these patients? First, wait and see. Just perform MRIs and wait. Second, microsurgery. Third, different types of radiation. Fourth, medical treatment with Avastin that can be useful in some patients with NF2, but normally not for the long term. And most of the patients finally undergo surgery, resecting the tumor, normally resecting the cochlear nerve, and then undergoing ABI, auditory brainstem implant. And we all know that most of these patients don't get really good results when speaking about open set discrimination. So in the last years, cochlear implantation has emerged as a new tool to treat these patients. When resecting vestibular schwannoma, we know that sometimes we can preserve the cochlea, we can preserve the cochlear nerve, but still the patient is deaf. So what's the rationale of this procedure? So we know that this anatomically spared cochlear nerve may be able to transmit an electrical sign generated by a cochlear implant from the cochlea to the brainstem. We were involved in a multi-institutional study about implantation in patients with vestibular schwannoma with Hospital Gregorio Marañón in Madrid and the Grupo Otológico in Piacenza. Here you can see these hospitals. We studied 15 patients, half of them, 8 patients with NF2, 7 patients with sporadic vestibular schwannoma. Here you can see that the patients in the NF2 group were younger with larger tumors, and the patients in the sporadic group were a little bit older with smaller tumors. So how was surgery performed? First, in the NF2 group, in half of them, it was simultaneous translap and cochlear implantation. In 3 of them, it was staged, so a middle fossa retrosigmoid was performed trying to preserve hearing. It wasn't preserved, so a staged transmuscular approach to perform cochlear implantation was done later. And in 1 patient, cochlear implantation was done just after radiotherapy when hearing decreased. And in the sporadic group, simultaneous translap resection of the tumor and placement of the cochlear implant was done in all of the cases. The important thing is that in all of these cases, the decision of placing or not a cochlear implant was individualized. It was just decided by the surgeon as he or she saw the cochlear nerve. What were the results in this study? So here you can see that of the 15 patients, 85% developed closed set discrimination and 64% had open set discrimination. On the long term, there were 62% of users in the NF2 group and 61% of users in the sporadic group. So would you say these are good or bad results? Well, you can say that as a general rule, CI in patients with vestibular schwannoma, with acoustic neurinoma, are somehow in between what you get with CI in conventional postlocative patients and what you get with an ABI. So we published these results some years ago. This is the paper. But this brings us to the key point, which is how can we know the status of the cochlear nerve? So how can we know intraoperatively if we should or not place a cochlear implant at the same time we resect the tumor? So the second part of this talk would be about assessing the functionality of the auditory nerve by using an intracochlear test electrode first in standard cochlear implantees. There are different ways to assess the cochlear nerve status. So if we see this picture with the auditory pathway, we can use promontory stimulation. In this technique, we perform an electrical stimulus and we have auditory perception. The problem is here the patient has to be awake, so we cannot use promontory stimulation intraoperatively. We can use ABR, that is an acoustic stimulus and electric response, mainly if we have or not wave 5. We can use this, but not in patients undergoing translab. Why? Because you need an integrity of the labyrinth to perform intraoperative ABR. You can also use, and we'll talk about that today, electric ABR. So here there's an electrical stimulus that you can place in different parts and get electric response, mainly wave 5. So the stimulus can be on the round window or it can be intracochlear. And being intracochlear, it can be performed with a cochlear implant, or it can be performed, as we'll talk today, with an intraoperative test electrode. Another way of evaluating this cochlear nerve status is SYNAP. In this case, you have an acoustic stimulus, but instead of recording brainstem response, you're recording directly from the cochlear nerve. The problem here is that it's not so easy to place the electrode on the cochlear nerve during surgery. And finally, you can also use ECAP. So there's an electrical stimulus to the cochlea and you record from the cochlea too. This is what you normally use during conventional cochlear implantation with neural response telemetry. So we are going to focus on using electric ABR with an intracochlear stimulus with a test electrode. Where we're involved in Lassaletta University Hospital with people from MEDEL, especially Marek Polak and Julio Rodrigo, and another institution in Spain, in Badalona, in the development of this test electrode. So here you can see how it looks. There are 3 active contacts, and there is also a ground electrode. So here you can see in this picture the intraoperative setup used for recording the electric ABR signals, both with the test electrode and with the cochlear implant. In this part of the study, we wanted to test the method in conventional CI patients and to compare the electric ABR between the test electrode and the CI. So there were 10 CI candidates, all of them with MEDEL devices. All of them underwent a conventional facial recess approach, and we compared the ABR, the electric ABR, between the test electrode and the CI, and we also evaluated the speech performance. So electric ABI were evoked in all the 10 patients, and we found no difference between the test electrode and the CI response. Here you can see both pictures comparing for the same patient the response with the test electrode on your left and with the CI on your right. And you can see the response is very similar. In this picture, you can compare the latencies. There were no significant difference among the latencies, both using the test electrode or the CI. And all patients achieved useful hearing in this study. We published these results in Otology Neurotology a couple of years ago. So at this point, we can say that this test electrode is really useful to assess the functionality of the cochlear nerve, specifically, or at least in this conventional cochlear implantees. And that brings us to the last part of the study, which was to assess the usefulness of this tool in these difficult patients with vestibular schwannoma. So here we have included both NF2 and sporadic tumors, all of them undergoing a translab approach, and the key was to compare the electric ABR before and after tumor resection in order to decide with this information if CI was placed or if not, if ABI was placed at the same surgery. So in this video we'll see how it works. This is an NF2 case. You can see here a tumor, a cystic tumor on the right side. So we are performing posterior tympanotomy, opening the round window and placing the test electrode. So we record, and in this particular case we see a positive response, so we go on with tumor resection. In addition to preserving the facial nerve, always in vestibular schwannoma, we have to preserve the cochlear nerve here. So here you can see a very nice dissection of both facial and cochlear. We take out the tumor, and finally you see the preservation of facial and cochlear nerve. So here again we are going to measure. We place the test electrode inside the cochlea, and if we are lucky enough, there will be a positive response. So this means that we can place the cochlear implant. So we seal the craniotomy with fat. We're going to take out the test electrode and we insert a conventional cochlear implant. In this case, Flex 28. This is a negative case. This is an NF2 case. In this particular case, there was no response with the test electrode. So in this situation, we move to the ABI. So here you can see the Luschka foramen. So we are going to place the ABI. So as you can see here, this tool is useful to decide intraoperatively between CI and ABI. I'm going to show you the preliminary results of an ongoing study performed in 3 institutions, institutions in La Paz University Hospital, but also the Ramón y Cajal University Hospital in Madrid and the Trias y Pujol University in Badalona. Here are the co-workers. So we have studied 21 cases with a mean age of 47 years, 9 NF2 and 12 sporadic cases with a mean PTA of 58 dBs and a mean maximum diameter of 15.4 millimeters. So I can tell you that so far we have found a very good correlation between the surgical findings, so how the surgeon thought the cochlear nerve was, and the electrode response. We have one false negative case. This is an interesting case I want to show you in detail. This is an NF2 case. Here you can see vestibular schwannoma on the right side and trigeminal schwannoma on the other side. So this patient underwent translab approach, and there was a positive electric ABI with the intraoperative electrode before tumor resection. So we resected the tumor, and after that, in spite of an anatomically preserved cochlear nerve, there was no response with the intraoperative electrode. Here you can see there was no nice response, no wave 5. So in spite of this, the cochlear nerve looked so good that we placed a cochlear implant, and the results were really good. Here you can see a PTA of 36 dBs and speech discrimination score of 75% at 65 dBs. And interestingly, for these patients with negative response intraoperatively, there was a nice response with the cochlear implant. You can see here the electric ABI 3 months following surgery. So we can consider this a false negative case. I'll show you a possible false positive case that wasn't so at last. So again, you can see here NF2 case, really difficult case. So in this particular case, we were told there was a positive electric ABR response with the test electrode following tumor resection. You can see here a possible wave 5. So in spite, we were not sure of preserving the cochlear nerve, cochlear implant was placed, and there was no auditory perception and no discrimination in this case. So, with the cochlear implant, this is a response you can see. So we learned that this was false positive, so it wasn't really wave 5, but an artifact created by facial stimulation in this case. So just to show you two examples of different possibilities you can have, but as I told you, mainly in most of the cases we have really good correlation between the status of the cochlear nerve and the electric ABR response. So to conclude, we can say that CI is an alternative method of hearing restoration in certain NF2 patients or patients with a vestibular schwannoma in the only hearing ear, and lately we are seeing that also in sporadic vestibular schwannoma, just patients with normal hearing on the other side. Second, that this intraoperative testing of the cochlear nerve with electric ABR is a suitable method to test the integrity of the auditory nerve. We are sure of that, at least in normal cochlear implantees. And as I showed you in this ongoing study, these results after tumor removal are really promising, with good correlation between the surgical findings and electric ABR. And finally, of course, we need a correlation with the long-term auditory performance to see what happens with these patients on the long term. I want to thank and acknowledge all the co-workers. Here are the co-workers of the first study of cochlear implantation in patients with vestibular schwannoma, the co-workers of the study in normal cochlear implantees, and here you can see the co-workers of the ongoing study. So that's all. Thank you very much for your attention.